For many patients, breast cancer patients that need chemotherapy, especially in the adjuvant setting, they are treated with a chemotherapy that belongs to the anthracycline class of agents. And these agents can actually affect the cardiac function. So typically, we consider getting a baseline cardiac ejection fraction assessment before they have these agents to predict or to find out if they have a normal baseline before we give them an agent that can cause more cardiotoxicity. But the guidelines, if you look at the guidelines and the practices, they're not very standardized. So some institutions and some physicians will get an echocardiogram on every breast cancer patient that's going to have these chemotherapies, while other institutions will select a higher risk, older population. So we wanted to find out, if we do these tests on all our cancer patients that are having this type of chemotherapy, how many of them would actually have an abnormal baseline, especially if they're asymptomatic. And two, we wanted to try to figure out if we could predict using the traditional cardiac risk factors of these patients who will actually have an abnormal echocardiogram, so we don't have to get the test on everybody. And in an era of concerns about cost, it would help to be able to select the population of patients that actually need that baseline cardiac assessment. The baseline population, so actually what we did is we went back to a database at the Yale Cancer Center or Yale University that included patients who had a test called an ERNA scan, which is similar to an echocardiogram. And we selected out the breast cancer patients. There was about 701 patients that had a test at baseline before starting their treatment. These patients, the nice thing about this study is that when they had that test, they were given a questionnaire, so they were able to report, whether they had hypertension, diabetes, were they smokers, did they have cardiac disease, or if they had family history of cardiac disease. So we looked at this population of 702 patients, and we looked at those cardiac risk factors to try to see if you see more of those risk factors in the patients that had an abnormal baseline versus the ones that didn't. And then we went back to confirm that these patient-reported risk factors are correct. We reviewed the charts of approximately 80% of the patients to try to confirm that they did actually have a diagnosis of hypertension or diabetes.
So what we found was that in our patient cohort, 2% of patients had baseline low cardiac function. And interestingly enough, there were no risk factors that predicted for this. Furthermore, looking at the cost effectiveness, it was indeed beneficial and cost effective to screen every patient for cardiac function before giving anthracycline or trastuzumab. This effect may be a little diminished in those patients who serve to benefit the most from anthracycline, where the benefit of that therapy may outweigh any risks of cardiotoxicity.
When we looked at the cost-effective analysis in the higher risk breast cancer population that tends to benefit the most from the anthracycline, we did not find that it was as cost-effective as in the general breast cancer population. So that might be a subpopulation of patients that needs to be studied further.